So the second paper is the outcome and complication following repair Achilles tendon slip avulsion injury using a double row SutureBride techniques. So I have no disclosure. An acute rupture of Achilles tendon is one of the most common tendon rupture in athletes. So the most common location is mid-substance, which is usually located 2 to 6 centimeters above the calcaneus due to its relative hypovascularity. Periosteal slip avulsion has been reported and is defined as detachment of Achilles tendon and at its insertion with or without small bony fragments. Unlike mid-substance, a periosteal slip avulsion is rare injury. And the treatment of this injury is challenging due to a high pull-out strength from the triceps sole and poor bone quality, actually if it occurs in elderly patients, and inadequate tissue to repair because you don't have the distal stump, and sometimes it's difficult to reattach the tendon to the bone because of you have tension more on the proximal stump. So there was a several technique has been reported in the previous literature to be successful treatment for this type of injury, including tension band wiring, suture fixation to the bone tunnel, tie rope, various techniques of the SutureBride construct. However, there's currently a little evidence in literature regarding surgical techniques as well as outcome and complication following a slip avulsion Achilles tendon injury. So the purpose of our study is to demonstrate the outcome and complication following a double row SutureBride technique for treatment of periosteal slip avulsion Achilles tendon rupture. We have a prospective case series of 7 patients who had Achilles tendon slip avulsion injury between 2015 and 2018 were enrolled in this study. So the treatment procedure including Achilles tendon debridement, remove small fragment, gastrocnemius lengthening, calcaneal exhaustectomy, and reattachment of Achilles tendons. A functional outcome, we use general health by short form 36 in both physical and mental component subscale. For foot-specific measure, we use a FAM score in both ADL and sport activity. And for pain, we use a WAS score. And clinical outcome include activity of daily living, work, and sport. For surgical technique, we use a midline incisions as based on the angiosome theory. We want to go on the midline so the flap can have a blood supply from the peroneal artery on the lateral side and then tibialis posterior from the medial side. Then we evaluate the rupture. You can see the gap at the end of the tendon, and here was the calcaneus. This is a true slip avulsion injury. Then we will perform debridement of Achilles tendon. If they have present of the small fragment, you need to excise first, and then we will debridement the tendon. You can see here, most of the time, the patient have underlying insertional Achilles tendinosis with the thickening of the tendon. You may need to trim it down at less than 6 millimeters. So this will be allow you to put it back to its new footprint without any bulky or bump on the back. If you leave it under debridement after finish the surgery, the patient not going to love it because they have a protrusion of the Achilles tendon. So after that, we will perform a gastrocnemius lengthening. So you can see this video. Most of the time, you cannot push the tendon back at the original footprint in neutral angle dorsiflexion. You're going to have a small 2 to 3 centimeter gap. So you're going to push it back only when you do maximum plantar flexion. So patient not going to love it. So that's why you need to do the gastrocnemius lengthening. So then after perform the lengthening, you'll be able to push the Achilles back where the ankle in neutral position. So this is the reason why I do the gastroc lengthening. So try to offload, and I can push the Achilles tendon back to the new footprint. So after that, we perform the calcaneal exhaustectomy. You can see here, you can imagine if we put the Achilles tendon back to the footprint like that, it's not going to attachment. You may need to clean out the necrotic and bad tissue, and then also perform calcaneal exhaustectomy, bring the good vascular bed for the new tendon to reattach. And then after that, we will reattachment the tendon back there by using a double row SutureBride technique. We can use a 4.75 civil lock with the fiber tape and 2 on a proximal row, and the other 2 on the distal row. And here's after we finish, and then you can close the wound. So the post-operative protocol, so we will let the patient with the dorsal blocking splint with early motion 0 to 2 weeks. After 2 to 4 weeks, patient will allow weight bearing as tolerated. And after 4 weeks, we are allowed to do full weight bearing. Here was the result from our study. We have 7 patients. Average age was 40 years, male 6, female 1. Body mass index is 26.9. Follow-up was 15 months, and operative time was 108 minutes. There was significant improvement in terms of functional outcome, including short form 36 in both physical and mental component subscore, FAM score in both ADL and sport, and also decreased pain from 9 to 1. And time to return to daily activity around 5 weeks. Time to return to work was 7 weeks, and time to return to sport was 6 months. So the sleep avulsion injury with or without calcaneal tuberosity fragment is a rare condition. There has been 32 cases reported in the 6 publications since 1998, and they use different techniques. So our series was our second largest series, and we was accepted and we published in the journal Times next year. So this is the surgical challenging for treatment of sleep avulsion tendon rupture. A double-row SutureBride demonstrates a better biomechanics because it's significant larger contact area and load that leading to higher peak load to failure compared to other construct. And it's also lower complication compared to other techniques such as the bone tunnel. You can break the calcaneus, or the suture knot can irritate the skin on the bottom of the heel. However, the limitation in this study was a short term of the follow-up and relative small sample size. However, the strength in this study we use all validated outcome and same surgical technique and performed by single surgeons. So in conclusion, a sleep avulsion type is a rare condition that can be seen both young and elderly patients. The sleep avulsion patient may be present similar to the mid-substance rupture. So lateral radiograph or sometimes MRI will be helpful to diagnose these conditions. A double-row SutureBride technique seems to be an effective technique and demonstrate promising results with minimal complication. Thank you for your attention.